Welcome, medical students, to today's lecture on the topic of heart failure with preserved ejection fraction, HFpEF. In this in-depth exploration, we will delve into the complex pathophysiology, diagnostic challenges, risk factors, comorbidities, molecular mechanisms, advanced techniques for diagnosis, biomarkers, pharmacological and non-pharmacological management, coexisting cardiovascular conditions, prognosis, novel therapies, patient education, and lifestyle modifications in HFpEF. In HFpEF, impaired relaxation and increased left ventricular stiffness lead to diastolic dysfunction. Abnormalities in filling, relaxation, and compliance raise end diastolic pressure, reducing cardiac output and causing heart failure symptoms. Myocardial fibrosis, chronic inflammation, and endothelial dysfunction are key molecular mechanisms, along with impaired nitric oxide signaling and increased vascular tone. Diagnosing HFpEF can be challenging due to its overlapping clinical presentation with other cardiac conditions such as hypertensive heart disease or valvular heart disease. Clinical symptoms include exertional dyspnea, fatigue, and exercise intolerance. However, these symptoms may also be present in other forms of heart failure. A comprehensive approach, including a thorough medical history, physical examination, and diagnostic tests, is necessary to distinguish HFpEF from other cardiac conditions. Echocardiography remains the cornerstone for diagnosing HFpEF by assessing left ventricular diastolic function, measuring left atrial size, and evaluating for other structural abnormalities. HFpEF is caused by various risk factors and comorbidities, such as hypertension, diabetes, obesity, chronic kidney disease, and aging. These conditions affect the heart's ability to relax and function properly, leading to the development and progression of HFpEF. Understanding the molecular mechanisms underlying HFpEF pathogenesis is important for developing targeted therapies. Chronic inflammation, endothelial dysfunction, myocardial fibrosis, and impaired nitric oxide signaling all play a role in the development and progression of HFpEF. Accurate diagnosis of HFpEF requires advanced diagnostic techniques beyond clinical assessment. Echocardiography remains the primary modality for evaluating left ventricular diastolic function, assessing left atrial size, and detecting other structural abnormalities. Cardiac magnetic resonance imaging, MRI, provides detailed information about myocardial fibrosis, ventricular volumes, and function. It is particularly helpful in identifying early signs of HFpEF and quantifying the extent of fibrosis. Invasive hemodynamic assessment, including right heart catheterization, helps measure pulmonary artery pressures, pulmonary capillary wedge pressure, and assess ventricular diastolic pressures more accurately. It is reserved for cases where non-invasive testing remains inconclusive. Biomarkers play a significant role in HFpEF diagnosis, prognosis, and treatment response. Brain natriuretic peptide, BNP, and natriuretic peptide precursor B, NT-proBNP, are commonly used biomarkers in HFpEF. Elevated levels of BNP and NT-proBNP are indicative of myocardial stress and are associated with adverse outcomes in HFpEF patients. They aid in diagnosing HFpEF, predicting prognosis, and monitoring treatment response. However, it is important to note that their diagnostic accuracy and prognostic value may vary in different patient populations. The pharmacological management of HFpEF involves controlling hypertension, diastolic dysfunction, volume overload, and comorbidities. ACE inhibitors or ARBs can lower afterload, while diuretics may manage volume overload. Calcium channel blockers and beta blockers might improve heart rate and myocardial relaxation. Additionally, addressing comorbidities like diabetes and obesity improves outcomes. Non-pharmacological approaches play a vital role in managing HFpEF and improving patient outcomes. Lifestyle modifications, including regular exercise training, weight loss, and sodium restriction, have shown promise in reducing symptoms and improving exercise capacity in HFpEF patients. Exercise training, involving aerobic and resistance exercises, helps improve exercise tolerance, endothelial function, and skeletal muscle metabolism. Weight loss, particularly in obese patients, may lead to a reduction in systemic inflammation and improved diastolic function. Sodium restriction helps prevent volume overload and reduces the risk of exacerbations. Heart failure with preserved ejection fraction, HFpEF, is often accompanied by other cardiovascular conditions, such as atrial fibrillation, coronary artery disease, valvular heart disease, and pulmonary hypertension. These conditions complicate the management and prognosis of HFpEF. Atrial fibrillation impairs heart filling and increases clot risk. Coronary artery and valvular heart disease worsen left ventricle dysfunction. Pulmonary hypertension increases right ventricle workload. Comprehensive management is needed. Prognosis and risk stratification in HFpEF involve assessing clinical findings, imaging parameters, and biomarkers. Factors like age, gender, NIHA class, comorbidities, left atrial size, pulmonary artery pressures, myocardial fibrosis, BNP, and NT-proBNP can indicate worse outcomes. These factors assist in individualized management, but further research is needed. The quest for novel therapies in HFpEF continues, with emerging pharmacological, interventional, and device-based interventions being investigated. Several targeted therapies are currently under investigation, including agents that aim to reduce myocardial fibrosis, modulate inflammation, improve endothelial function, or enhance myocardial relaxation. Interventional approaches such as cardiac resynchronization therapy, CRT, and transcatheter interventions targeting the mitral or tricuspid valve may offer benefits in selected patients. Additionally, ongoing research focuses on exploring the potential role of remote monitoring and digital health technologies in managing HFpEF. Patient education in HFpEF is crucial for successful management. Effective communication improves understanding of the disease, treatment options, and adherence. Lifestyle modifications like exercise, weight loss, and sodium restriction should be emphasized. Supportive interventions and shared decision-making enhance outcomes. In conclusion, heart failure with preserved ejection fraction, HFpEF, is a complex condition that requires a comprehensive understanding of its causes, diagnosis, risk factors, and prognosis. Your knowledge and expertise in HFpEF will be crucial in improving patient outcomes. Thank you for learning about this important area.